Okay, so thank you very much for coming today. We're going to talk about the nutrition care process and relating it to chronic kidney disease specifically. But certainly this translates into other areas as well. So again, my name is Allison Steiber, and I'm from the Department of Nutrition at Case Western Reserve University. So just a brief intro to where it all began. Back in 2003, the American Dietetic Association adopted the nutrition care process as the way that they were going to go for documenting nutrition care. The definition that the American Dietetic Association uses is a systematic problem-solving method that dietetics professionals use to think critically and make decisions to address nutrition-related problems and provide safe and effective quality nutrition care. And Karen Lacey and Pritchard were two of the ones, kind of the mothers of the nutrition care process. And so they published this back in the Journal of the American Dietetic Association. So if you want to go way back and see their early thoughts, that's where that can be found. This is really a four-step process. I am going to talk a bit about screening because I think that's something that the dialysis world and thinking about chronic kidney disease that we don't do, that perhaps we could do to improve our process. And certainly in the hospital, screening is an everyday part of the system. So this is the iconic figure of nutrition care process, and I'll walk you through it just a bit to think through. So this is the screening and referral system, and we'll talk more about that in a minute, but it triggers the beginning of the nutrition care process. And so your first step is nutrition assessment, and I think that's one thing that in dietetics we do really, really well. We know how to assess. And so if you read the nutrition care process book or the International Dietetic book, see that it contains a lot of information on assessment. It's very detailed in the coding for assessment. So from assessment, then you're going to go to a step that's kind of a new concept for dietitians, and that is the diagnosis step. And in this, you're identifying the nutrition-related problem or problems. And by doing that, you're giving it a label. And this really helps us kind of think through systematically, if they have the label of inadequate protein intake, then what are the steps that we're going to do to figure out the etiology, what interventions are appropriate for that, and what outcomes do we want to monitor, if possible, systematically to determine if our intervention was effective or not. So this diagnosis is really pivotal in thinking about what's going on with your patients. From the diagnosis, we go to the nutrition intervention, and there is a little bit of a link here that this diagram doesn't really clearly elucidate, and that's the PES statement, the problem, etiology, and signs and symptoms piece, and we'll go through that as I kind of walk you through the steps. And that PES statement does link to the nutrition intervention. And one of the things that I find most interesting about the nutrition care process, although the coding has gotten much better, each kind of version that they come out with a new book and the new color, they seem to do a much better job delineating what the assessment pieces are and the different parts of the nutrition care process. But the intervention piece still is a little ambiguous, and they don't have concrete, what I would call the details of the interventions that we do every day. Refer to healthcare team, discuss changing particular medications such as phosphate binders or oral supplements, discussing ways to get access to foods for our patients, discussing transportation issues. All those things that we really probably do without even thinking of. The nutrition care process at this point doesn't allow us to be able to delineate that in our documentation and have codes for that. So that's a piece we have to think about. And I will show you in our algorithm, we have done this. We have delineated these interventions in great detail. And so I'll kind of show you that. Then, of course, there's monitoring and evaluation. And one of the things that you need to know is this is cyclic. So those same assessments that you did to determine your nutrition-related problem, those are the same things that you're going to monitor to determine if your intervention is effective. And so that's the monitoring and evaluation piece. And at each step, you're documenting what's going on with your patient. I must say, so at this stage, if your nutrition-related problem has resolved, they can exit out of the system, out of the circle. But if it hasn't, then you continue looping around, trying to determine why hasn't it resolved, What can you do differently? You know, are there other interventions that can be tried? Do you need longer time? So it's continually reevaluating, kind of that systemic quality assurance, only at a micro level of your individual patient. So let's talk a bit about screening. So there are a lot of screening tools out there. I think in the hospital, frequently it's done by nursing or by a non-dietitian, although when I worked in a hospital, we had diet technicians that did our screening. So I think it really depends on your facility and your institution. But there are a lot of validated tools that already exist that maybe in the outpatient setting are used more frequently, such as the Determined Checklist for elderly, the Geriatric Nutrition Risk Index, the Mini Nutrition Assessment. Marie Ferguson validated the Malnutrition Universal Screening Tool, and then there's just the Malnutrition Screening Tool. And all of these have been validated in different populations. And so, you know, part of thinking through how to trigger into the nutrition care process is how do we effectively identify who's at risk? And that's a big issue. These can be performed, as I said, by a dietitian or not. The key is that you flag the people that are at risk. And as I said, as the dialysis setting gets more and more intense, we have more acuity, higher level of patients, as obesity and hypertension continue to escalate, we are going to see larger numbers in the dialysis center, and we are going to have to figure out how to screen our patients. And so one of the things I will show you in our algorithm process is we have a screening tool that is the first step of our algorithm, and that will help you identify those patients. The other thing I want to mention about screening is in many areas of nutrition, not just chronic kidney disease, there are things other than protein energy wasting that may trigger you to have an intervention. For instance, it may be in the dialysis world or the CKD world, it may be elevated phosphorus, hyperphosphatemia, or hypo-25-hydroxy. You may have low vitamin D status, or you may have high potassium, or high PTH. So those might not be triggered on any of these traditional screening tools, but we still need to know about them. We need to pay attention to them, and we need to do it in an early phase of our care so that we get optimal outcomes. So step one, once we've entered into the nutrition care process, we've determined the person is at risk nutritionally, they enter the nutrition care process. The assessment is the systematic process for obtaining, verifying, and interpreting data needed to make decisions about the cause and nature of your nutrition-related problem. And this really consists of kind of 5 categories, and I would suspect all of you already do this. You know these, you do these, you may just not think of them in a formal way. So there's the food nutrition history, the biochemical data, medical tests, procedures results, anthropometric measures of any kind, waist circumference, etc., physical exam findings, and client history. And we know that all those things really impact how we determine what the nutrition problem is, and not just the nutrition-related problem, but what's causing that problem. Because our intervention, as we're going to find out, is really triggered by the etiology. So it's almost equally important to determine what the problem is and what the cause of that problem is, so that you can intervene appropriately. And I'll give you some examples of that. So here's kind of, Esther Myers published this back in 2008 in the Journal of American Dietetic Association. As you can see here, she's given domains to her assessments. And this has the most terms of any component of the nutrition care process. 301 terms. So we love to assess. We're very good at it. So there's the nutrition and food history, 155 different terms, the anthropometric terms, the biochemical data and medical test terms, your nutrition-focused physical findings, and your client history. And when I show you kind of the linking process, how we connect the steps, there'll be columns that'll show you these codes that I'm talking about now that relate to the nutrition-related problems, so that you link those. And one of the things I must say about the book that the ADA puts out on the nutrition care process, it does a nice job showing us how to link assessment with nutrition-related problem diagnosing. It has nice tables, nice ways of saying, oh, if these are my findings in the assessment, here are the diagnoses to consider. So if you haven't invested in that book, it is a nice resource for you to think through. So here are the different examples of some of the areas that we see. So we have biochemical data, which you guys already get, especially in the dialysis center. Every month you're going to get biochemical data. In an outpatient CKD clinic, you might not get it every month, but you might get it every 3 months or every 6 months. So, you just have to think about whenever it comes available to you and use what you have. But of course, that's the limitation of biochemical data. Then the anthropometric measures, there's been a lot of great data that's come out on hand grip strength and how it predicts malnutrition inflammation syndrome and how it predicts mortality. So waist circumference, another great predictor of cardiovascular mortality. These things are easy, they don't take a lot of time, and they give us some really interesting information to help us focus our intervention on what our patients are really able to do and not able to do. The nutrition-focused physical exam is another really important component, and I always give the example when I talk about it, and people say, well, why bother? The physician's looking at them, the nurse is looking at them, why should I bother to look at them? And so one of my favorite examples is I used to work on the renal floor in a hospital, and the nurse came up to me and said, this person is not eating or drinking anything. You need to go in there with your menu, and you need to figure this out. And so I went in and I started chatting with the person. At that time in our hospital, we were trying to institute doing oral exams and nutrition-focused exams. And so I said, very dutifully, even though I wasn't totally on board with that whole thing, I said, would it be okay if I looked in your mouth? Can you stick out your tongue? And the person did, and their tongue was covered with kind of a brown, shag carpety look, and I said, does it hurt to swallow your saliva? And they said, yes, it hurts to swallow anything. And so I went back out to the nurse and I said, I think your person has thrush. And I think if you get some antifungal in there and rinse it around, within 24 hours, your patient's going to be eating and drinking both. But somehow in all the assessing, they missed the fact that this patient had thrush. And so very rapidly they fixed it. It's an easy fix, and the person was eating again within 48 hours. So just by taking 5 seconds to look at that person's tongue, I was able to really assist them in being adequately nourished. So it's just something to think about. It doesn't take a lot of time, but you can occasionally reap big benefits. It's part of the big picture. And I would say the subjective global assessment is right in line with that. So what about this nutrition and food and nutrition history? There are, again, 4 components of this. So we have the food intake piece, which I think we think a lot about. Taking a 24-hour recall or even just a quickie recall and kind of using the exchange groups to determine if they're getting the right amount of calories, whether it's doing an intensive one, an outpatient, or a food frequency questionnaire, whatever it is that works for you to assess their intake. And certainly whatever technique you use, you want to be able to know if your patient's getting too much phosphorus, too much potassium, adequate protein, adequate calories, what their sodium intake is, what their potassium intake is. All that is important, and if you don't ask them what they're eating, you're never gonna know. And so I think that's especially, we wanna make sure and ask them if they eat a lot of processed foods. They could be taking in huge amounts of phosphate additives, and we wouldn't even know it if you don't ask them what they eat. Then we have to think about their awareness of nutrition and health. And in a world of huge amounts of data out there and huge amounts of information, they're getting information, perhaps correct, perhaps not correct, from all over the place. And so you have to know the perspective that they come in. Are they wearing magnets as you speak with them? What are they doing? Do they take supplements? All that kind of mental, so that you can open a rapport with them to be more effective in your intervention. And you won't know that unless you ask. Same with physical activity and exercise. We had a very interesting speaker at our Strategy 2 meeting in Las Vegas for the National Kidney Foundation. He felt that dietitians should move over and start working on exercise. And I think he got a little bit of shocked faces from the dietitian, but he felt that dietitians really need to be the ones promoting exercise and physical activity in the dialysis center. And they asked, well, what about accesses? What if someone has an access in their arm or their leg? Will that prevent them from doing exercise? And he said, no, I'm an access physician, that's what I do, and I'm here to tell you that you can promote exercise even in your patients with tender accesses. Give it a little time to mature, but then they should be able to do exercise. So something to think about, making sure you're asking the patients physical activity and promoting that. And then a big area, especially in the Cleveland area, and I would bet this is true in many big population areas, is food access. Do they live in one of the food deserts in the middle of the inner city where they don't have access to fresh fruits and vegetables, to fresh foods, to whole foods? Or are they only eating their foods from a convenience store or a liquor store, and thus they have to eat processed foods or fast foods, and we wonder why their phosphorus is super high. So you have to understand their food availability as well. All right, so let's move on to the client history. The client history, again, has different components. The medication and supplement history. And one of the things you're going to note in our assessments for this algorithm is that we have a question, just 3 little questions, but you have to click on it to know that you've queried whether or not your patient is taking an herbal supplement. And so we have that. We also have a very extensive medication list for you to select which medications your patient's on if you think that's impacting their nutritional status. Social history, medical health history, and personal history as it relates. So this is one of the slides that's going to show you a bit about connecting the pieces. And so if you see this, you have this column that shows you the nutrition diagnostic terminology. You have a column that shows you the nutrition assessment and/or ME, and ME stands for monitoring and evaluation code. And then you can kind of take a look. So let's say that you have assessments that indicate these different assessment codes lead you to a certain level of finding. You can look at this column and say, well, what diagnosis would that be appropriate for my patient? And this would be the code for the nutrition diagnostic terminology. And the book that they have very nicely connects this, but you can see that this is in restriction or omission of energy-dense foods. So perhaps your patient is having weight loss or poor intake of caloric foods. That will kind of give you the category for intake, the nutrition assessments that you've probably done to determine that, and the things to monitor as you move forward. And this is another example in weight. I used interdialectic weight. So if you have somebody who's gaining a lot of weight between dialysis treatments, that would be the code area you would use, and here would be the things that you would want to monitor, and they have it both for adult and pediatric patients. So they really tried to meet the needs of the clinicians. It's a slow process. Those of you who've been following this for a while know that it started out pretty limited, and that they're growing, and they're getting better, and they're meeting with different groups, different populations to try and make it better. All right, so step 2 is really this diagnosis. And I think originally when we started thinking about diagnosis, we think about medical diagnosis, but that is not what this is. And that's why I sort of try to focus on the words nutrition-related problem, because that's what this is really. It's a label that's identifying the nutrition-related problem. And so you can see the official definition is the identification and labeling of the specific nutrition-related problem that dietitians are responsible for treating independently. Now, when we say that, obviously there's a huge amount that you do clinically that you can't do independently and make it happen. For instance, you're monitoring a tube feed, and you notice that they're getting insufficient protein, and therefore you want to increase, maybe change the formula that is a higher protein content, or change the rate so that it increases the protein and calories and all the micronutrients. You can't go into that medical chart necessarily and say, change the formula or change the rate. You have to consult with your healthcare team or your physician to make that happen. So that's where it becomes a little tricky on this are responsible for treating independently. But what is your area of expertise? What is it you cover in the dialysis center? Do you look at phosphorus and calcium? Do you look at iron and the algorithm of iron? Do you just monitor protein energy wasting? Do you do everything? So that's whatever your scope is in your facility, that's what we're talking about here. And it is really the link between the assessment that you've done and your intervention, and I'll show you how that works. So it allows the practitioner to really set these realistic and measurable outcomes for each patient or client. And that is a key to this. And especially in dialysis where you're seeing them every month, you don't want to click, and we've had dietitians do this, 6 different diagnoses and try and intervene all on them in 1 month. That's just not very realistic for the patient or for you who has time constraints. So we want to think about prioritization. What is the priority of that patient? Is it getting insufficient protein? Or if they're an obese patient who's already taking in great amounts of calories and protein, no non-healing wounds, is it maybe adding a micronutrient, a micronutrient-filled multivitamin supplement? Or is it, trying to get them to do exercise, in a physician-approved way? What is it that we want you to do? What is the priority for that patient? This is, as I said before, not a medical diagnosis, and it can change from time to time, visit to visit, as you see the patient. Unlike a medical diagnosis, which I always say doesn't change. It's like being pregnant. You either are pregnant or you're not pregnant. And so eventually you deliver, obviously. But the diagnosis of a medical diagnosis is much more permanent, whereas a nutrition-related problem, today they can be taking in inadequate fiber, and the next time they see you, they can be taking in excessive fluid. So you have to be able to change as their condition changes. And so this is the little diagram for the nutrition diagnosis. You can see there's 60 diagnostic terms. This is broken down into the food and nutrition intake, which we just talked about. Clinical terms, which is more about utilization, nutrient utilization, substrate utilization, and behavioral environmental. And we'll talk a little bit about that as well. And so this is kind of what the intake domain looks like. And you can see there's different classes, whether it's caloric, oral or nutrition support intake, fluid, nutrient balance, fat, protein, carbs, vitamins, minerals, so there's a whole plethora of opportunities for this. So what are some examples that we can use as diagnostic codes in the chronic kidney disease population? So you might say something like they're getting inadequate energy intake. I can envision somebody who you find that they are having weight loss, their C-reactive protein's high, they have low appetite. Then you may want to say something like inadequate protein energy intake for that person. Or you might have a person who's coming in with 9 kilos of fluid on between runs, and you just can't dialyze it all off. And because of that, their BUN is really high, et cetera. They're having a lot of uremia issues. So then you might say excessive fluid intake is your diagnosis. Inadequate calcium, excessive phosphorus intake. So there's a lot of different ways you can use this. The intake domain is really big. It's where we really have our most impact in terms of nutrition. This is the clinical domain. So the clinical domain is nutrition findings or problems identified that relate to medical or physical conditions. So functional balance, biochemical balance, weight balance. So all these go in the clinical domain. Some potential nutrition-related problems or diagnoses you might use are impaired nutrient-related lab value. We see that a lot. A lot of dietitians did that in our algorithm study. So they would use altered nutrition-related lab PTH, or altered nutrition-related lab 25-hydroxy, or something, albumin, very common, altered nutrition-related lab serum albumin. So they identified that as the problem, and then they tried to determine what was the cause of that alteration of lab. So you can think about it that way. Behavioral environmental domain. So the behavioral environmental domain includes nutritional findings, problems that identified that relate to knowledge, attitudes and beliefs, physical environment, access to food, and food safety. And I'm sure all of you have had patients where you've questioned whether the food at home was, they were eating it or storing it or preparing it in a safe way. And I had a patient once who I was talking about protein foods, and we had this whole dialogue about increasing their protein intake, and they said, well, that's great, but I don't have a refrigerator. And so then you have to rethink, okay, what can we give him that doesn't require refrigeration that can be high protein food? So just really understanding that dynamic with your foods. So as you can see, some potential diagnoses: limited adherence to nutrition-related recommendations. It's a nice way of saying non-compliant, sort of. Undesirable food choices. That's another one that you could think of using. So this is kind of, when we begin to think about diagnosis, as I said before, we begin to think about cause. What's causing this nutrition-related problem? And it's equally important to identify cause, because that's what we're going to intervene on if possible. So here are some etiology categories, and as you'll notice they look very similar to the nutrition-related problems that we just thought through. So what I often say is when you're thinking about what's your etiology versus what's your nutrition-related problem, think about what can I manipulate? What can I change? What can I have an impact on? So, if they have an altered nutrition-related lab parathyroid hormone, and the etiology might be the fact that they have a lack of active vitamin D. They're not receiving active vitamin D. So you can recommend to your healthcare team that they start giving a particular analog for active vitamin D, Hectorol or Zempla or something like that. Now you've intervened on the etiology and you're improving the nutrition-related lab. So it's kind of the way that you want to think through, what is it that I can intervene on? What is it that I can have an impact on that will improve their nutrition-related problem? Okay, so some of the categories they talk about are attitudes and beliefs, the cause or contributing factors related to the conviction of the truth of some of the nutrition statements or phenomena, feelings or emotions, so kind of where the patient's coming from. What are their feelings on whole foods? What are their feelings on supplements? What are their feelings on listening to any nutrition advice at all? So you can think about that. Cultural etiologies, knowledge etiologies. In dialysis, at least in English, when we talk to our patients about protein, potassium, and phosphorus, they all start with P. And you know, I've had many conversations with my mother, who is completely healthy and very smart lady who's in her 70s, and she'll be like, stop. I don't know which one you're talking about now, you know. So, you know, that's confusing. You've got a lot of parameters that your patients are thinking about that relate to their nutritional status. So you want to be clear that they know what foods contain protein, what foods contain potassium. And we may think they know, and they may smile and nod at us a lot, but they may not really know. And so trying to make sure the knowledge piece is there, somehow figure that out. Physical functioning etiologies, whether they're able to shop effectively and walk with their shopping cart or get transportation to the shopping, and physiological and metabolic parameters, or etiologies. So this kind of connects that piece. So here's your diagnosis. So let's say we take poor nutrition quality of life. So the etiology, maybe they have an altered body image, and that's in the category of their belief and attitude. So you kind of begin to see how this all connects. Let's see, disordered eating pattern. Maybe you have a very overweight person who eats large amounts of food, and the etiology might be societal, biological, genetic, and or environmental related obsessive desire to be thin or just to eat. So you ought to think about that, especially if you think about a bulimic patient, a person with bulimia. That could be part of your etiology. So what is this PES statement? So kind of the statement that brings this all together, that tells the nutrition-related problem, the etiology, and what your evidence is for that nutrition-related problem is the PES statement. And it's problem, etiology, and signs and symptoms. And so the problem is your diagnostic label, the etiology is what's causing that, and your signs and symptoms are those defining characteristics. So if your patient has excessive caloric intake, your sign may be results of a 24-hour recall, plus the fact that their BMI is maybe 45. Or you may use weight gain, or other things that you can use that are signs and symptoms or evidence of that excessive caloric intake, okay? So this is just an example. The patient interview reveals patient consuming 3 to 4 cups of pasta for dinner, 24 ounces of regular soft drinks at lunch and dinner, and a candy bar for an afternoon snack. The patient's blood work reveals a hemoglobin A1C of 11% and a fasting blood glucose of 350. So you might say your patient has excessive carbohydrate intake related to a knowledge deficit of carbohydrate-containing foods, as evidenced by, and there's your evidence, the hemoglobin and the fasting blood glucose. And so the linkers, the kind of terms that we use to be consistent, are this related to and as evidenced by. And so that makes your statement, and it's actually a really nice way to concisely tell your healthcare team what's going on and what's causing it. And many years ago, before ADA had come out with this nutrition care process, we began at our hospital to follow Marian Kite's diagnostic terms and use that. And she too suggested these links. And I must say, the healthcare team I was working with really liked that. They liked the fact that it was one concise statement that brought it all together. And so you can think about that. So step 3 is the intervention. As I said before, this is an area that needs more detail, more delineation, so that we really know what it is we're doing in a precise manner that lets us know what was effective and what wasn't effective for each nutrition problem, or for the biggies at least. So the purpose is to resolve or improve the identified nutrition problem by planning and implementing appropriate nutrition interventions that are tailored to the patient's needs. So an intervention is directed at that etiology, as I said before, wherever possible, although sometimes you can't. So think about your person who has insufficient calorie and protein intake related to recent stroke and dysphagia. I'm not going to fix dysphagia, right? I can't fix that. And then you give the signs and symptoms as evidenced by. So instead of being able to actually target that intervention or that etiology, I'm going to have to go and try and fix the signs and symptoms or try and aim myself at the problem. So I might have to try and give them food through either modified texture or enteral nutrition using tube feed. So you can't always do it on the etiology, but sometimes you can. Each problem should have a corresponding intervention. Now, as you know, some problems have the same intervention. So, for instance, if I might say altered nutrition-related lab glucose, because their glucose is very high, plus altered nutrition-related lab hypertriglyceridemia, if my intervention is to provide an oral hypoglycemic or better insulin coverage, that intervention would probably resolve both the high blood sugar and the hypertriglyceridemia. At least that's one would hope. But once you have that resolved, then you come back and check. Did it? Well, maybe it resolved the blood glucose, but it didn't resolve the hypertriglyceridemia. And so then you have to think through a different intervention or a more effective intervention. So, it's kind of that cyclic way of thinking about it. So, intervention. Oh, and I guess one other point I want to make about that is specifically in hemodialysis and chronic kidney disease, we actually have a paucity of data on interventions, and we have almost zero randomized clinical trials. I can think of, in the literature now, probably 5 or 6 within the last year or two that really test nutrition interventions. We have a whole lot testing drugs, but how many times do you see a randomized clinical trial testing patient education? So a lot of what we do, we don't have randomized clinical trials to back us up. And we have to use clinical judgment, or we have to use epidemiologic data, or we have to use other ways to prove that what we're doing is gold standard and evidence-based. So, it's not always perfect. So you can't always whip out the FIND trial and say, here, you should use interdialectic parenteral nutrition because, oops, this didn't quite show that effectively. So we don't always have perfect evidence to show what we want to. But the goal is to do it based on scientific principles and rationale. All right, so here are the intervention code terms. There's 74, and you can kind of see they're broken down into areas that are very thoughtful. Nutrition, food and or nutrient delivery. So that's your oral supplement, that's giving them adequate food, actually delivering them adequate micronutrients and macronutrients through whatever system. There's nutrition education. There's nutrition counseling, which obviously is different, and we have some new models that have come out about that. Education is just providing knowledge or information, whereas counseling is behavioral change. And coordination of nutrition care, working with your healthcare team to make sure they have access to Meals on Wheels or the senior center, or they have the correct transportation to make sure they can go shopping. So it's that coordination of care. That's the 4th one. Now I've kind of branched out nutrition education so you can see a little bit more detail on this, so they are getting more detail. So this is your initial or brief nutrition education versus your comprehensive nutrition education. Purpose of the nutrition education, priority modification, survival information, etc., versus the comprehensive, which is more detailed. Purpose of the nutrition education, recommended modification, advanced or related topics. So if you think about a person with diabetes, I can really relate this to somebody giving information to a person with diabetes. Maybe initially, when you haven't really determined what stage of change they're in yet, you might just give them a brief bit of information so that, survival kind of level. Versus if they come back to you and they're really interested in carbohydrate counting and an insulin pump, and so you give them much more advanced levels of education and spend a lot more time with them. And so then you can begin to see how these would work. Result interpretation, skill development, those kinds of things, okay? So it's a different level, and you can code it differently. So the 4 nutrition categories of nutrition intervention I already went through. You can see them listed here again. Food and nutrient delivery, we talked about that. The education versus counseling, and that coordination of care. And as I said previously, we're still working on identifying interventions more tightly, and I'll show you in the algorithm we've tried to do some of that, but that is not, those are not from the nutrition care process. Those are us doing that for our study and our algorithm. So take that as you may. So there's a ton of interventions, and they may be difficult, but it's important for best practice to be developed. So you have to try and document as much as possible what you're really doing with the patient so we can see whether it's effective or not. And it may be very specialty specific, and we'll talk about that. So the fourth and final step is this monitoring and evaluation, and it determines whether the patient or client is achieving the nutrition intervention goals. So if your goal is that the patient is consuming 75 to 100% of their estimated nutritional needs, then you go back and you say, okay, let's do a 24-hour recall and find out, are they consuming that? Yes, no, and then you back that up with other data. Are they having any weight loss? Have they had weight gain? What's their biochemistries telling you? So it's that whole piece that you're trying to pull together and monitoring to see, did the patient follow through with your interventions, your recommendation? Did the physician follow through with your physicians or recommendations? Were they able to do it? Like they may have nodded and smiled and said, sure, I can do that, and then they really found out that they couldn't. So it's that whole piece of trying to figure out, did it work? And if it didn't, then it's time to modify, right? So we want to measure outcomes, and in our algorithm we have a really nice system to show you how we can do that and how we can watch trends over time, and we'll show you that. And then obviously, really anybody can collect data, but it's the interpretation of that data that makes the dietitian so unique in what they can do. Did this really work? Interpreting the data. I used to say in the dialysis center that the nurses could give the patients back their labs, but they couldn't tell the patients really what the labs meant. And we can. We can really explain to them what those labs mean and how that functions. So that's that interpretation piece that's important. And here are the terms for monitoring and evaluate, and they're basically the same as the assessment terms. They're very similar, and so they go through all the different sections as the assessment ones did. What about documentation? So I'm not going to talk a lot about this because part of the algorithm is it's documenting for you, and we have a summary page that will show you the whole nutrition problem, what you chose for your etiology, what you chose for your intervention for each problem, and then the outcomes, it will summarize for you the outcomes over time. But documenting in the nutrition care process really involves the A, or the assessment, the diagnosis, the intervention, and then monitoring and evaluating. Now, if you're a person that used to SOAP a lot, you remember in the SOAP we had subjective and objective, and then assessment. Well, all three of those things are now in the A part of the ADIME note. And so you have to kind of think that through. And that it's only the P, or the plan, that gets broken out into intervention, monitoring, and evaluation. And diagnosis is really a new component to it. And the diagnosis piece involves your entire PES statement. And so this kind of tells you that. Subjective and objective, the PES statement, what are your overall goals and objectives for each diagnosis must have an intervention, and then monitoring and evaluation, what you're going to monitor, how you're going to know whether this was effective. So let me just give you a little brief introduction to our algorithm so you can see how this works. So this is kind of the schematic to let you know kind of a big picture version. So we have a screening tool that we've developed that includes protein energy wasting as well as the other main components that we think renal dietitians look at on a regular basis. The assessments to be performed. So if your person screens out to be at risk, then they're triggered to do individualized assessments. So the way this would work is if, let's say, everything was perfect on your screening form, but your potassium was like 6.2. So then the assessments that you're triggered to do would only relate to determining what's going on with that potassium. So we tried to be very focused because obviously there's a ton of assessments you could do if you had a lot going on. Now the challenge is a lot of our dialysis patients and our CKD patients have a lot going on. And so it ends up that there are a lot of assessments that may be triggered for you to look at. It is your clinical judgment whether or not you need to do each of them, or whether you just want to open it, look at it, and say, nope, that's not what I want to do with my patient. I don't think that's relevant, or I don't have the capacity to do that, and then close it and move on. So that's an important piece of this. It's your clinical judgment to determine what to do. We're not telling you you have to do any of it. So that's the assessments. Each assessment triggers this kind of cascade of process, a potential list of diagnoses that are related to the outcomes of your assessment, what the input that you put in for your assessment, and then you determine the diagnosis that you think is appropriate for your patient. Same with etiology, same with barrier, and finally the interventions. So you may say, well, what's barrier? You didn't talk about barrier in the nutrition care process, and that's true. There's been some very good literature in the world of hemodialysis that tells us that it's very important to look at barriers. And so we have added an additional step where you try and determine, are there any barriers that are preventing your patient from achieving optimal nutrition status? Do they not have access to food? Do they not have enough money? Do they not have, so there's a lot of things going on that even if we give them the perfect intervention, they still may not be able to achieve it. So that's why we have interventions, and then we have outcomes, and then it kind of goes back again in the next month, or maybe the next visit, you screen them again, and it's cyclic like this. If there's no risk, then they are kicked out, and you don't have to worry about them again until the next month when you re-screen them again. So just a few considerations beyond protein energy wasting. Currently, all those screening tools I showed you before, Determine, MNA, MUST, MST, none of them contain anything but protein energy wasting parameters. So we had to create something that went beyond that, and that's what we did. So this is our screening tool. Let me give you the quick and dirty. This is weight trending. So we ask you to put in the weight and height, any past weights you have, and then our screening tool automatically calculates the body mass index of the patient. Then we say, you ask yourself, have they had weight loss? Now sometimes in dialysis, we're trying to get them to lose weight so that they can get on the transplant list, and that we want that. So then we just ask you to say, if they had weight loss, was it intentional weight loss or not? And so then you would click yes or no. Did they have excessive interdialectic weight gain? Yes or no. Do they have an amputation? Yes or no. And then the rest, the middle part are all biochemistries, key labs that we think are important. Albumin, phosphorus, PTH, potassium, cholesterol. If they're diabetic, we would ask you to enter their hemoglobin A1C if it's available. Adjusted calcium, are they on EPO? And if so, what's their hemoglobin? Then we ask you to think about appetite. I think I mentioned previously that appetite is really important in thinking through our patient, and this particular question has been extremely well validated in the literature. Have you been bothered by a lack of appetite during the past 4 weeks? Not at all, somewhat, extreme, moderately, or very much, or extremely. So click that. And then we're trying to get at the inflammation piece, and you don't always have a C-reactive protein to tell you whether they're inflamed. So we're trying to ask some questions that might answer that for us. So that would be, do they have a wound that's not healing? Do they have current signs of infection? Fever, a urinary tract infection, an abscessed tooth? Those all could be leading to systemic inflammation. And finally, has the patient been hospitalized in the last month? So you fill out the screening tool, then the computer tells you whether or not they're at risk, yes or no, and then you're triggered to do individual assessments. So what the dietitian will see on the screen are the potential assessments, the potential diagnoses, interventions, and outcomes. Behind the scene, the computer is using an algorithm where we've set up a huge matrix of kind of information letting the computer know which assessments to bring up, which diagnoses to bring up, which interventions, etc. So the dietitian doesn't see that though, and let me show you kind of the example. So here's all the potential assessments that if someone was just a complete train wreck, they would all come up. But you can always click this little box that says, no, I don't want to see all of them. I just want to see those that pertain to my patient and their screening data. And then you'd get a much shorter list of assessments. And you can see down here the algorithm tells you that the patient's at risk. So the key to this assessment is you have to open each one to move to the next step. I'll say that again. You have to open each one to get to the next step. If you don't open one, it'll have this little word new in parentheses. That means you haven't opened it. Now it's your choice whether to actually input data. So in some of these, are very common, and we hope that you're looking at them every month, and we want you to enter that data. But sometimes you don't have the data, and sometimes you can't, or sometimes you don't feel it's clinically relevant. So then you use your clinical judgment to not enter any data. That's fine, but you still have to open it and look at it. And I'll show you how that works in a bit. So this is the diagnosis list that would come up potentially. You select the ones that you think are appropriate for your patient, and then you click Save and find etiology. So then the computer says, okay, altered nutrition-related lab value, hemoglobin A1C, excessive intake from oral food, beverage, increased nutrient needs, fiber, fluid, overweight or obese. So for each one of those diagnoses, the computer is going to generate potential etiologies. We picked 4 diagnoses. You're going to have a good amount of etiologies coming out from each intervention, but think about what you do clinically. You probably already do this mentally, you just don't have the big list sitting in front of you, so it's not quite as daunting. So this is just trying to get you to think through what you're already doing clinically and document it in a systematic fashion. So in this case, those were the 4 diagnoses. Here are the suggested etiologies. The dietitian selects ones that she thinks is going, or he thinks is going on. Is it the glucose-lowering medications not optimized, excessive carbohydrate intake, excessive dietary intake? Now the italicized words in the parentheses behind show what went on before. So this etiology was driven or derived from excessive energy, which you selected as a diagnosis. So you kind of see your pathway of your decision-making process. So, and always in below, you can see the diagnoses you selected. And now we have a mechanism where if you go, oh, that's really not what I meant to do, I want to go back and change that. I don't want that diagnosis. Now we have a mechanism where you click and you can go backward and redo it. So you're not locked in anymore. For a while you were locked in, but we've changed that. So here's the list of barriers. You can see the more diagnoses you select, the bigger expanded it becomes. And you can see the history behind in italicized, and you can see all the different barriers that you can think through. Are these things preventing my patient from being successful nutritionally? Is it difficulty limiting quantity of food consumed, lack of motivation, difficulty modifying food choices, financial barrier to obtaining their medicine? So you're dealing with these things all the time. This is just a way of documenting it, okay? And then finally, the interventions. So you may educate, and you can see how detailed we've gotten here. Educate patient to limit portion sizes of high energy foods. That might be a piece of education. Utilize motivational interviewing techniques to identify potential barriers to healthful eating. Determine high nutrient, low energy dense foods for patient as a preserved, who has preserved appetite. Refer to social worker. So all these different things might be interventions that you do without even thinking about them. We're just asking you to detail out what it is exactly you do, all right? Then you have, these are the outcomes that will come up the next month that will automatically be rolled into your assessments so that you can monitor over time the effectiveness of your interventions. We have a section here which is the notes section. So if you want to say, oh, patient stated they didn't have much of an appetite, but they were very excited about their diet, or something like that. So you can write freehand notes to yourself in this as well. And so that's very important. And as I said, you can always rewind to see the logic of your choices and to change your choices. So this is what our summary page looks like. So once you've seen the patient a second time, a subsequent time, you can click the button that says summary page and see what you've done. So here's the diagnosis. Here's kind of the group category that diagnosis is in. And here's all that happened. So let's say you picked overweight and obesity as your diagnosis. So that's in the group excessive energy. Here's your grouping. Here's the etiology was excess dietary intake. The barrier was their difficulty limiting quantity of food consumed. Their intervention was to educate the patient to utilize lower fat cooking methods and to prepare prepared foods. So you can really begin to see it all connected. What is it that you've done? What is it you plan to do? So you can go back and look at this next time and say, wow, this is what I did previously. Now this is what I'm going to see if that worked or not. And then we have this table below, and this is actually all on one screen. We just couldn't fit it well on our screen. But you have all the potential outcomes that might be listed, and you can see their changes over time. So this is somebody who'd been in our algorithm study for many, many months, and so you could follow. So you could, let's say, dietary carbohydrate intake. You can just track it over time. Well, we didn't have a great month there. So you can just track over time what's going on with your outcome parameters. And this lets you see trends and improves your ability to make effective interventions. okay? So after we did our initial pilot trial, we sent out a post-survey to see how the dietitians felt about using our algorithm study. And we were a little nervous and expected not as positive results as maybe happened, but we were very pleased at the results. So 85% of the dietitians that used the algorithm felt that it increased the time they interacted with the patient. And that was really one of our big goals, is that assessment enough. We want you to spend more time talking to your patient, more time interacting with your patient so you're more effective. So we really were excited by this particular outcome for our survey. And then we asked the question, did you feel that using the algorithm changed the quality of your interaction with the patient? And as you can see, a big red chunk said that it improved it. Nobody said greatly improved, but they did say improved. Some people said no change, and a few people said that it decreased. So we've got more work to do to make it even better. But we were very excited about this, that the dietitians thought that it improved their quality of interaction with their patients. So real quickly, I want to show you this live and in person, and I have just about enough time to do that. So this is a real person. Let me just get to the beginning. So this is a patient. So you would enter your initial data, the ethnicity, the dialysis start date, what country you're from, and then you'd come to this first screen, and all you'd see is this first little box on here, and you could click Screening Tool, and up would come our screening tool, and you could enter all your information into this. One of the things that we have to do in chronic kidney disease and maybe in other areas as well, is always ask the type of albumin assay you do. Is it a green or purple? So that we make sure we're comparing apples to apples. Also, if you're from a country that doesn't use conventional units, our screening tool will convert your international units to SI units so that you don't have to do that yourself. So that's so make sure if you're from somewhere who doesn't use standard units that you use international units, that you put them in that side, and then they will automatically populate onto this side. So you complete your screening tool, and then up will come assessments, a listing of assessments that are just determining on what screening information you put. And you notice when I click on it, like subjective global assessment, then you can see either if you're using the PG-SGA, the patient generated, all you have to do is put in what your screening outcome, what your outcome of that. However, if you're using the 7-point SGA, you can complete that right on here, and you can see here's the weight change information. You can put in your rating, the dietary intake information in your rating, GI, functional capacity, etc., your physical exam and the rating, and then the overall SGA score, and you'd enter that here. And then when you close this or enter, push enter, then the parentheses beside that shows as viewed or edit, and that's the way you know you've opened that assessment. So I've already opened all of these. I guess I wanted to show you the herbal over-the-counter one, so you could see kind of that's a little bit different. So you'd be triggered to ask, is the patient taking herbal or over-the-counter supplements? And you could say yes or no. Does evaluation of supplements indicate interaction with medications? Yes, no. And so you could enter that. And this piece really feeds into your etiology determination, not directly into your diagnostic determination. And so it just helps you figure out what's going on with your patient. So you can come out, oops, I think I actually needed to put enter there so we can move on to diagnoses. So once you enter, and I might have entered crazy information, so we'll see what diagnoses are generated here. Yeah, quite a bit. I was a little crazed. So you can just click. So let's say you say this person has inflammation, and maybe they have increased nutrient needs protein. So that's the only two I'm going to select out of this big potential pile, because I'm using my clinical judgment on that. All right, so that I'm going to save and find the etiologies. So here's the etiologies. Is it ultra route of feeding or insufficient energy? Food access, thus insufficient energy. You can go down the list and see, is it metabolic acidosis that's causing insufficient protein, or a poor appetite, or GI, or so what is it that's going on with your patient? So you can just select. So I'm going to say it's metabolic acidosis, and then I'm going to save and find barrier. And so then here's our list of barriers. So is it their dialysate prescription? Is it the fact that they have diarrhea contributing to this? Insufficient medication use? medication side effects, or do they have muscle breakdown? So I'm going to say it's diarrhea. So that I'm going to save and find my interventions. And so I've got some potential interventions to think through. Are they gluten intolerant? Do I want to evaluate for lactose? Do I want to educate the patient on dietary soluble fiber? Or consult the healthcare team to determine what's going on with this patient? Recommend diet alteration. So you can see the interventions are pretty specific that relate to diarrhea. So I'm going to say we're going to consult the healthcare team to determine the etiology. Because I don't know why they have a diarrhea. So I'm going to save and generate outcomes, and then next time, these are the outcomes I'm going to want to look at and see if they've improved since baseline. And if I click on my summary page, then I get this nice little thing saying, okay, here was the diagnoses I chose, here's the etiology, the barrier, and the intervention I chose to do, and these are my first baseline data. And next time I come, I'll be able to look at that and see if they've improved or not. Okay, and that's kind of the whole scoop, full circle of our nutrition care process algorithm that relates for chronic kidney disease patients. So with that, thank you very much for your attention. And if you have any questions, this is my email, and certainly feel free to give me an email. Thanks.